Good morning, everyone. And my name is Dr. LALIT VERMA, and we'll be starting this course on macular disorders. I know there is an overdose of some of the disorders, but we'll try to be as crisp as possible so as to spend more time on discussion. And I'm joined by an eminent faculty here, Dr. Raju, Dr. Dinesh Talwar, Anand Rajendran, Dr. Mallika, and Dr. Avnindra Gupta. And we will try to cover very, very common disorders which we have labeled as treatable macular disorders, where we can do something for our patients. You see, macular disorders are one of the most common disorders which we see in our practice. And because of advancements in diagnostic, primarily OCT, a lot of attention is now focused on these disorders. You see, way back, a couple of decades back, angiography was the main modality, but now I think OCT is done much more often, and OCTA is assuming more and more importance. And I pay a lot of attention to OCT because each of the comprehensive ophthalmologists should master this interpretation of the OCT and identify all these layers. Because today, believe me, all retinologists, in fact, all clinicians are dependent on the information provided by the OCT. And interference ho jati hai, beech mein thoda kar doge. And it's very important to show these photographs to the patient, because if you convince a patient that this is how a normal OCT looks and this is how his OCT in that eye looks, because once you show him, he becomes very much compliant to your advice. Because we should not just tell him that you have a CNVM or CSR or whatever. If you show him this is normal OCT and this is your OCT. And I think it's a must for all practices, not important only for retinal practices. It's important for all the practices, even for comprehensive. In fact, at a lot of centers, OCT is a must before cataract surgery also, routine cataract surgery also. Because it has been found by a couple of studies that even in a normal looking retina, 10 to 15% of patients do not have a normal OCT. Whether that has any impact on vision or not, that's immaterial, but normal OCT may not be there in routine cataract surgery also. So importance of gadgets in any case is that clinical diagnosis sometimes may take a back seat and gadgets the front seat, but why not? Because if they aid in the clinical judgment and obviously prognosis also. So this slide I'm very fond of showing, and I want every comprehensive to mug up these 10 layers. As a resident, we keep emphasizing all these 10 layers: disease of inner retina, what is inner retina, what is outer retina, and it's very important because it aids in explanation to the patient. Once we are talking to the patient, it becomes very useful. So because of the advancements in OCT, EDI, SSOCT, the focus is recently shifting from retina to the choroid, and hence you see these newer OCTs have programs where you can see the entire choroid apart from the retina, the choriocapillaries, the satellar layer, the Haller's layer, and even the suprachoroidal space. And hence you see things like pachychoroid spectrum have assumed a lot of importance. Although pachy by definition means thick choroid, but all thick choroid do not form the pachychoroid spectrum. So for it to be included as a pachychoroid spectrum, you have to have atrophy or thinning of RP, and the Sattler's layer and the Haller's layer becomes very, very prominent. That is, but we are learning a lot about pachychoroid spectrum, and it's ever evolving kind of spectrum. And as of now, things which are included in this are central serous, then pachychoroid pigment epitheliopathy, neovasculopathy, PCV. They today all come under the spectrum of pachychoroid. In any case, I'm not going to take much time in introduction because we have a lot of disease to cover. But CSR, which all of us thought that we know in detail, recently has come back because a lot of new things are happening. And our own J.H. Chiplani from LV Prasad has a lot of interest into this and has reclassified CSR into two major subtypes, simple and complex. And this is the table which I copied from his publication. So with this is small brief intro, we will cover these 4 or 5 diseases, starting with the CSR CME by Dr. Raju, and then going on to CNVM by Dr. Dinesh, and then DME, current management, and how should we be approaching RVOs, and then surgery, what do we expect in a patient of CNVM and macular hole. So all of them will, I think, share some algorithms and do a lot of cases so that they can impress that this is the way to go in these diseases.